Hello, welcome to another presentation. Today we are talking about hematology and arthritis. So first of all, you have to read these concepts very well. Yeah. So take your time, pause the video, and review these concepts. What is osteoporosis, bone sclerosis, osteophytes, Lytic lesions, and bone erosions. Okay, you have to review them, Google, and also you have to watch some examples about that, okay, or see some examples about that, or example of the diseases about that, so you can understand better our presentation today. Okay, saying that, after you review all these five key concepts, so we can start with our lecture today. So about the hematology, we are going to talk about two key diseases, sickle cell disease and multiple myeloma. The first is sickle cell disease or sickle cell anemia. So you know how significant is the morbidity and mortality of sickle cell disease in this country. It's a very common disease, and you're going to see a lot of patients with this kind of pathology. So let's go straight to the radiological features. Sickle cell disease is going to produce cardiovascular changes and bones changes as well. So let's go to start talking about cardiovascular changes. The more important cardiovascular changes is cardiomegaly. Okay, so this a lot of patients with sickle cell disease develop this kind of pathologies, and at the physical examination, we want to feel a murmur. You want to hear a murmur. Okay, so that means there is a vascular problem in your heart, or valve problem in your heart, which will produce a cardiomegaly. So you have to request a chest X-ray for this one. The second thing is bone changes. So why the sickle cell disease produce bone changes? There are four main causes that can produce that. It's because of the ossification due to macrohyperplasia, thrombosis and infection, secondary osteomyelitis, and growth defect. Let's go to talk about the ossification. So first of all, the ossification would produce a huge change in the spine. So the vertebral bodies will to become soft at the central part, and then go to get the appearance of big concave vertebra, fish mouth of H-shaped vertebra. So this pathology go to appear in around 70% of the patients with this kind of pathology, sickle cell disease. In 70% of the patients with sickle cell disease, which is a virtually pathognomony of sickle cell anemia. Okay, is pathognomony of sickle cell anemia. So you have to take a closer look to this kind of sign, biconcave shaped vertebra or H-shaped vertebra. So I can show you here. There are a few examples of biconcave vertebra. You can see the arrows there. Also, you have to look at the old explanation. Why is this shape? Remember, the central part of the vertebra is too soft, so there is compression of the end plate due by the intervertebral disc, and then the vertebra body is going to take this shape. It's very important to know that. Okay, so let's pass to another cause of the ossification. In this case, the hair on end striations sign. Okay, so what happened here? The density of the scalp reduced and decreased a lot. So this was to decrease the thickness for the outer table. Remember, in the calvaria we have the diploid, the outer and the inner table. So because of the decrease of the thickness of the outer table due to the widening of the diploid, they go to appear this shape of the outer table. Okay, it's like a hair. It's like a hair. So for that reason, it's hair on end striation of the calvaria sign. I repeat again, there is decrease of thickness of the outer table. It's almost going to disappear. So the diploid go to take this shape. Go to take deep shape. It's common pathology. It's very common. So for any sickle cell patient you have to request at least chest X-ray and lateral skull X-ray. Okay. So let's move on to the other pathologies, or the most common in the sickle cell disease. So you're going to see this chronic fat. You can see this sclerosis areas. You can see the arrows, okay, or these opaque areas in bones. In this case, this is the knee. You see there is some opaque and loosened areas. Remember what is opaque and what is lucency, okay. And then the other thing of saying on the infanto is a bone within bone appearance. Bone with the bone appearance. You can see it's like there is another bone inside of the long bone you are watching this. You can see both cortex, like there are two cortex of the bone. What is marked for the head arrows. And then the other thing is bone deformity. Bone deformity, you can see it here. We go to mark for the blue head arrows, shortening of the third and fourth metacarpals are phalanges. Okay, so it's very important for you to know that there is this patient will come into the OPD with severe pain. Sometimes shortness of breath, but you want to see that more in your next year and then but you have to always take this in your mind. Sometimes also coming with the pain on the extremity. When you come with this pain, you have to think maybe there is a bone infection. You have to request for the X-ray. Okay, so let's go to talk about now of the multiple myeloma. So multiple myeloma is the most common primary malignant neoplasm of the skeletal system. It's going to appear after 55-60 years, and this is very common disease. In the radiological features, we have two very important. First, radiology has a number of rules in the diagnosis and management of multiple myeloma. So the radiology can suggest the diagnosis or exclude other causes. Also can assess possible mechanical complications like pathological fracture and assess disease progression. For you, the most important thing is the disseminated multiple myeloma has two common radiological appearances. The first one is numerous well circumscribed lytic bone lesions, okay, and generalized osteopenia. So the first one, well circumscribed lytic bone lesions, remember they are lucent. Lytic is lucent, so that means there is a punch out lucencies. We call it pepper pot skull or raindrop skull sign. Pepper pot skull or raindrop skull sign. The other characteristic in this West circumscribed mutilation is the industrial scalping. And then in the case of generalized osteopenia, we have this vertebra compression fracture or vertebra plana. And for you, it's very important to know for the diagnosis of multiple myeloma. Also, the first thing is a plain X-rays. There is a special study for that, which is a skeletal survey. So all patients are suspecting multiple myeloma. The first thing you have to request is a skeletal survey, which is essential. Is not only the diagnosis of multiple myeloma, but also in assessing response and preempting potential complications. Okay, as a pathological fracture, like I mentioned before. So survey consists of the following things: lateral skull, frontal chest fin, cervical, thoracic, lumbar spine, shoulder, pelvis, and femurs. So you can see it is around 14 to 16 X-rays at the same time. Remember, this is the first study you have to request in case of multiple myeloma. Other thing you can do is request a CT scan or MRI. CT scan or MRI, but the most important, remember, is a skeletal survey. So let's go. I will go to some examples about Pepe, the Pepe Pot School or Rainbow School. You can see this is the scalar X-ray, lateral scalar X-ray with all these lucency, small or lucency areas scattered to the scar. You can see that in your left. Then on your right, which is marked for the head arrow in blue, you can see the vertebral planar. So what happened here? It's different with the big concave vertebra we have. You have saw it in the we talk about in the sickle cell disease. So in the sickle cell disease, remember, is the central part of the vertebra which is soft. For that reason, they're going to get this H shape. But in this case, all the vertebra is soft. All the vertebra is soft. For the reason, goes to appear like a planar, like a single line. It's very important to know that the difference between H-shaped vertebra and vertebra plana. Now let's go to talk about endosteal scalping. Endosteal scalping. This happening if any part of the body, maybe in long bones or even the vertebral bodies can appear. You see there is a thickening. You can see the blue arrows. There is a thickening of the cortex of the band of the bones. Also with this defect that the endosteal scalping. Sometimes it's very difficult to see, but another times it's very easy. The other pathologies related with the multiple myeloma have all kinds of lytic lesions. You can see this in your face at the left. This lytic lesion over there is a loosened area. In the second, you see there is like something is eating the bone. Something is eating the bone. That's another example of this horrible disease. And then the third is a CT scan with the abscess, just to mention that. So it's very important to not remember about multiple myeloma. You have to go and stop the video and review again. Now let's go talk about very fast about arthritis. So arthritis, like the name says, is the inflammation of the joints. Inflammation of the joints. There are general radiographic signs of arthritis. So we have a general radiological signs of arthritis, such as osteophytes, joint space narrowing, articular sclerosis, bone erosions, subchondral cyst, joint fusion, and intra-articular calcified bodies. Now this is the classification of arthritis. We have non-inflammatory arthritis, inflammatory arthritis, septic arthritis, metabolic arthritis, and miscellaneous group. There is a lot of type of arthritis. They are very, very difficult to diagnose the specific arthritis in general. So let's go to talk about osteoarthritis. They are the simple general osteoarthritis, inflammation of the joint. In this case, you can see with the white arrow, the osteophyte is a long osteophyte over there, and then the subchondral sclerosis is all this around of the blue arrow or the opaque area. That's the sclerosis, and the asymmetric loss of the joint space, which is marked for the blue arrow. You can see the space there is more reduced than the rest of the joint. So the joint space over there is more reduced than the rest of the space in the joint. Now this is an example of rheumatoid arthritis. This is a common arthritis you want to see a lot in during your life as a doctor. So it's very common and it's very, very painful, and they go to produce a lot of deformation. The main sign of the rheumatoid arthritis is the erosions. Okay, erosion is a typical feature of the rheumatoid arthritis. Then let's move on and we have arrived to this very important disease, diabetes mellitus, in the musculoskeletal system. So this disease is very important for the repercussion in the society. We have a lot of patients here, not only in Ghana or Africa, it's around the world. So diabetes mellitus affects appendicular and peripheral structures, more commonly ankle and feet. Foot and ankle ulcers can produce as well. We can produce a flat foot, hammer and claw toes, osteomyelitis, and fractures including fragmentation of bones and disorganization of joints. Also neuropathy changes, okay? And could produce diabetic myopathy. Diabetic myopathy. These are some examples of what can produce the diabetes in our extremities. We have this ulcer, which is tend to occur in the pressure point, including on the head of the first metatarsal, medial part of the foot, and posterior to calcaneus. That's very important to know. Other disease diabetes can produce is the peripheral vasculopathy. You can see all the stenosis, and stricture in this X-ray. Even in your left, you can see a normal vascular pattern of the extremities. In the V, you can see this disease can produce the diabetes in the vascular system. This is a sample of atherosclerosis. Atherosclerosis, there is stenosis, obstruction, and stricture of the vessels. This is a very common disease you want to see a lot from next year. You want to see a lot of ulcer and diabetic foot. And there to finalizing, we have avulsion fractures. So avulsion fractures are frequently occur in diabetes patients. The common sites include the knee and the ankle. You can see there is a avulsion fracture in this case of the calcaneum. So include the knee, the ankle, and calcaneum as well. But it's more common the knee and in the ankle. So for you have to know the difference between the avulsion fracture or the mechanism in the child and in the adult. Okay. So I think these are all for today. Remember, you have to pay attention to our first slide where you have the concepts. You have to read the concept very well, look for examples on Google. Then when you are clear about that, you jump into the conference, jump into the presentation. Otherwise, you don't want to understand very well. So, okay, remember, you have to know the differences between the children and adult in the avulsion fracture. Also, the difference between H-shaped vertebral body and vertebral band is very important to know. Okay, that is all for now. See you in the next presentation.